This is how to read a chest x-ray, a systematic approach. So first part of any study really, but particularly chest x-rays, you should always look at the history and the indication. Is this something that's being done for an acute process, a change in status, or is it more routine, i.e. rollout tuberculosis? If they're nice enough to give you any symptoms, you can look for that because that will change your pretest probability for things. And then of course, particularly on the inpatient side, pull up any priors or CTs that you have for comparison to kind of help to see if there's any change. You should never really read blind, know why you're reading it, so you can put out some sort of useful report. First step, really, aside once you look at the images, is to determine, okay, are these images actually appropriate for me to dictate? The main thing with an AP chest x-ray is that you're looking at rotation. Are the clavicles equidistant from the spinous process or not? If the clavicles are widened in one direction or another, that indicates the direction at which the patient is rotated. So for instance, if this right-sided clavicular distance from the clavicular head to the spinous process was increased relative to the left, that means that the patient is rotated to the right side. Next, you'll look at inspiration. Is this something where the patient has basically breathed out all of their air and everything's collapsed, or is it an appropriate inspiratory effort? And that's defined as greater than or equal to 6 anterior ribs above the diaphragm. Next, you'll look at exposure. Exposure is how well you can see things. So the vertebra should be visible through the cardiac shadow. The vascular markings should be visible in the lungs. You can have under or overexposed images, even with digital radiography. If the quality is poor, note it in your report. So this is a limited study because of X, Y, or Z. Step 3, you'll look at the airways. First thing is the trachea. Is it midline? Is it deviating in one direction or the other? Typically, the trachea will move away from things that are causing mass effect or towards things where there's a vacuum, so like atelectasis. The carina, you're looking for the normal carinal angle, which is less than 70. If this is splayed open, greater than 70, it indicates left atrial enlargement or subcarinal adenopathy. Finally, you're looking for any air bronchograms. On something where there's a consolidation and you see air bronchograms, that's very suspicious for some sort of consolidation or a pneumonia. Next, you'll look at the cardiac silhouette. So a typical cardiothoracic ratio is less than 0.5, meaning the distance of the heart to the entire thoracic cavity. Greater than 0.5 suggests cardiomegaly. You can look at the cardiac borders. So on the right side, you've got your SVC, your IVC, and your right atrium. On the left side, you have your aortic knuckle, your pulmonary artery, and your left atrium, as well as, of course, the left ventricle. Any of these things that are obscured on either side indicate pathology in one location or the other. So obscuration of the right heart border is a right middle lobe opacity, whereas obscuration of the left heart border typically indicates a lingular, or if the diaphragm and cardiac silhouette is obscured, left lower lobe opacity. Next, you're going to look at the mediastinum, the superior mediastinum first. This is the aorta and the trachea. Widened superior mediastinum indicates some sort of aortic pathology, an aneurysm, dissection, or adenopathy, as well as, substernal extension of goiter, which can often look like a mass in the superior mediastinum. Next, you'll look at the hilum. So normal, the left hilum is slightly higher than the right. They're typically of symmetric size and density. If there is hilar fullness, it can be adenopathy or indicate engorged pulmonary vasculature. Bilateral hilar adenopathy can be seen in sarcoid, lymphoma, TB, amongst many other things. Unilateral hilar adenopathy is suggestive for malignancy or an infection if you have an opacity on that side. But again, that could still be a mass. Particularly, that's why the clinical history is useful, or if the patient has a background of emphysema, these things are all going to increase your suspicion for a mass. Next, you'll look at the lung zones. So I start in the upper zones. I'm looking at vascular caliber, any apical disease, TB, fibrosis, apical pleural scarring. Next, I'll look at the mid zones for perihilar masses, things that are obscuring the hilum, any consolidation. And then finally, in the lower lobes for, again, consolidations, effusions, or atelectasis. I'm looking for certain patterns when I'm looking at lung parenchymal disease, interstitial patterns, curly B lines, reticular nodular opacities versus ground glass or hazy opacities. And then, of course, the distribution. Is this a unilateral process? Is this a bilateral process? Is it particularly perihilar or central or predominantly peripheral? And these things are all going to change your differential as to what might be causing that opacity. Next, look at the pleural space. You're looking at the costophrenic angle. Ideally, they should be included in the field of view. On a AP or PA radiograph, blunting of the costophrenic angle from pleural fluid requires at least 200 to 300 mLs of fluid, so not an insignificant volume of fluid. You'll look at the fissures. The major fissures are not typically visible on the anterior view, but sometimes you can see the minor fissure on the right, and this can be used to localize lobar collapse if there's a collapse of a lobe. And then, of course, looking at the lung apex again and running along the entire pleural surface for any apical pneumothorax or pneumothorax of any sort, where I see the visceral pleural line, absent lung markings distal to that site. And of course, always check the lung apices because you can miss a small apical pneumothorax. Next, you'll look at the diaphragm. In a normal radiograph, the right is going to be slightly higher than the left because of the liver. This is 1.5 to 2.5 centimeters higher. Significantly elevated diaphragm can indicate some sort of phrenic nerve palsy or some sort of subphrenic pathology. I'm looking for subphrenic air under either one of the diaphragm. That is a surgical emergency if there's no explanation, because it indicates a hollow viscous perforation until proven otherwise. I'm looking for the gastric bubble, making sure it's on the correct side. There's no heterotaxy going on, as well as sometimes you can pick up a bowel obstruction with dilated bowel loops. Last, you'll look at the bones and soft tissues. This is something you don't want to miss. It's easy to just kind of gloss over, but you can often find occult fractures, masses of any sort, lytic lucencies, what have you. So you're looking at the clavicles, the scapula, the AC joints, the shoulder joints, looking for the subcutaneous tissues for subcutaneous emphysema that can indicate a small pneumothorax somewhere that you're missing. The breast shadow at times can be seen. This is a male, but in females, or any soft tissue calcifications. There you have it. That's the 9-step approach to a standard AP or PA radiograph.